2.9 million seniors lost their Medicare Advantage plan over the last 8 months. UnitedHealthcare, the largest Medicare Advantage insurer in the country, pulled out of more than 200 counties across 16 states. Humana exited nearly 200 more. Aetna dropped roughly 90 plans across 34 states. In Minnesota alone, a carrier called UCare abandoned the program entirely, leaving 158,000 enrollees without coverage. A study published in the Journal of the American Medical Association in February of 2026, led by researchers at Johns Hopkins Bloomberg School of Public Health, confirmed that forced disenrollments jumped tenfold, from roughly 1% historically to 10% in a single year. Nearly 3 million people were told their coverage was gone. That is the largest coordinated withdrawal from a senior insurance program in the history of American healthcare. And here is what almost none of those termination letters explained. Federal law contains a provision that gave every one of those seniors the guaranteed right to purchase a Medicare supplement policy without medical underwriting, without health questions, and without denial for pre-existing conditions. That right lasts exactly 63 consecutive days from the date coverage ends. For the majority who lost their plans on December 31st, that window has already closed. Most never knew it existed. For seniors being affected by mid-year plan exits still happening right now, and in 4 states where this right never expires, the window is still open. What happened to the millions who missed it, and what options remain for anyone on Medicare Advantage right now is what I'm going to walk you through. I'm going to walk you through 3 things. First, exactly why the largest Medicare Advantage insurers all pulled out at the same time, and why this is a financial decision, not a coverage decision. Second, the specific federal provision that gives affected seniors guaranteed access to a supplemental policy, including which plans qualify and the exact deadline. Third, a step-by-step breakdown of what to do right now if you received one of those letters, including the free government-funded counseling program that exists specifically to help you through this transition. Every source behind this video is a published federal filing, CMS data, or a peer-reviewed study. Patricia is 74 years old. She lives in Rochester, Minnesota, a city most people know because of the Mayo Clinic. She retired from a school district administrative position 11 years ago, enrolled in a UnitedHealthcare Medicare Advantage PPO that same year, and never had a reason to question it. Her cardiologist was in-network. Her primary care physician was in-network. Her monthly premium was $0. Every September, her annual notice of change arrived with minor adjustments she barely read. In October of 2025, the letter was different. UnitedHealthcare was discontinuing her PPO plan in her county. The letter listed her options: switch to a UnitedHealthcare HMO, choose a different Medicare Advantage plan, or return to original Medicare. What the letter did not explain was that returning to original Medicare without a supplemental policy would expose her to 20% coinsurance on every doctor visit, every scan, every outpatient procedure, with no annual cap on what she could owe. Patricia called her doctor's office. They told her that Mayo Clinic had already dropped most UnitedHealthcare and Humana Medicare Advantage contracts. The provider network she had counted on for a decade was dissolving regardless of which new plan she chose. She looked into buying a Medigap supplement to pair with original Medicare. She is 74 with a history of atrial fibrillation and controlled hypertension. 2 Medigap insurers asked for her medical history. Both declined to offer a policy. A third insurer offered coverage but quoted a premium nearly double the standard rate because of her health history. On a fixed retirement income, it was not an option. What Patricia did not know, and what the termination letter did not tell her, is that because her plan was terminated by the insurer, federal law gave her the guaranteed right to buy that Medigap policy with no medical questions at all. She had 63 days from the date her coverage ended. She did not know the window existed. It closed. She found out about it 3 weeks after it expired from a ship counselor her neighbor mentioned over coffee. By then, there was nothing to be done. She is now on original Medicare with no supplemental coverage, responsible for 20% of every medical bill with no ceiling on what she could owe in a given year. A single cardiac event could cost her more than her entire annual income. Patricia is a composite. Her details are drawn from published accounts of seniors in Minnesota, one of the hardest hit states in the country. But her situation is only one version of what is happening right now. There are seniors in rural counties where every Medicare Advantage option has vanished entirely. There are seniors whose plan technically survived, but whose hospital, their cancer center, their surgeon, their entire medical team dropped out of the plan's network. To understand why all of this is happening at once, you need to understand 3 forces that hit Medicare Advantage simultaneously. The first force is a change in how the federal government pays Medicare Advantage insurers. In 2024, the Centers for Medicare and Medicaid Services replaced its old payment calculation, the V24 risk adjustment model, with a new one called V28. The new model reduced the number of diagnosis codes that qualify for higher reimbursements from roughly 9,800 to 7,800. In simple terms, the government looked at how insurers were billing and concluded they had been coding patients as sicker than they actually were, then collecting inflated payments based on those codes. The projected result is approximately $11 billion in reduced payments to Medicare Advantage plans across the industry. Bobby Hunter, the CEO of UnitedHealthcare Government Programs, said publicly, and this is a direct quote, "The combination of CMS funding cuts, rising healthcare costs, and increased utilization have created headwinds that no organization can ignore." Government funding for Medicare Advantage dropped roughly 20% between 2023 and 2026, and it gets worse. In July of 2025, UnitedHealth confirmed that the Department of Justice had opened both criminal and civil investigations into the company's Medicare billing practices. The allegation is systematic upcoding, inflating or fabricating patient diagnoses to trigger higher government payments. It has been described as the largest Medicare Advantage fraud investigation in history. The second force is medical costs. UnitedHealth reported medical care expenses of $78.6 billion in a single quarter of 2025, up 20% from the same quarter a year earlier. Their profit dropped 19%. Their stock price fell roughly 55% from its all-time high. The business model that made Medicare Advantage profitable for insurers is breaking. The third force is the hospitals themselves. 21 major health systems have dropped Medicare Advantage contracts in 2025 and 2026, including Mayo Clinic, Mount Sinai in New York, Providence in California, and Moffitt Cancer Center in Florida. The reason is consistent across every case. Medicare Advantage plans pay hospitals less than what traditional Medicare pays for the same procedures, and the gap has widened. Prior authorization denials are increasing, reimbursements are delayed, so the hospitals are walking away from the plans. Here's what this means for you. The insurers built a product around zero premiums and supplemental benefits. They funded it with government money. They maximized that money through aggressive diagnosis coding. The government tightened the payment formula. The hospitals said the reimbursements were too low. And now the insurers are exiting, and the seniors who trusted those plans are the ones holding the termination letter. What happened to Patricia in Minnesota is playing out across the country in different forms. Harold is 71. He lives in a rural county in South Dakota, one of the states where the JAMA study found more than 40% of Medicare Advantage enrollees were forced to disenroll. His carrier was a small regional plan that served 3 counties. When it exited, Harold went to the Medicare Plan Finder to search for a replacement. There were 0 Medicare Advantage plans available in his county. He is one of the seniors living in the 122 counties across 13 states where no Medicare Advantage plan exists at all. He defaulted to Original Medicare. He does not have a Medigap policy. If Harold has a cardiac event and spends 5 days in the hospital, a stay that might cost $60,000, he will owe roughly $12,000 out of pocket with no cap beyond that. His annual income from Social Security is $22,000. Harold takes medication for type 2 diabetes and has a knee replacement scheduled for next spring. That surgery alone could leave him with $15,000 to $20,000 in coinsurance under Original Medicare, nearly his entire annual income. He is considering canceling it. He had 63 days to purchase a Medigap policy at guaranteed issue rates with no health screening. His county has no SHIP counseling office within reasonable distance. Nobody explained the deadline. It passed. Linda is 68. She lives in the Tampa Bay area of Florida. Her Medicare Advantage plan was not terminated. It survived the 2026 exits. But in December of 2025, Moffitt Cancer Center, Florida's only National Cancer Institute designated cancer center, dropped its Aetna Medicare Advantage contract. In July of 2026, Moffitt dropped Humana Medicare Advantage as well. Linda was diagnosed with stage 2 breast cancer in the fall of 2025. Her oncologist practices at Moffitt. Her treatment protocol was built there. When the contract ended, she had 2 choices: continue at Moffitt as an out-of-network patient at dramatically higher costs, or transfer mid-treatment to a new oncologist at a different facility. Transferring cancer care is not simply a matter of choosing a new doctor. It means a new physician reviewing months of records, potentially adjusting the treatment protocol, and introducing delays in a disease where timing can determine outcome. Linda spent weeks searching for a comparable oncologist within her plan's remaining network. She could not find one at an NCI-designated facility in Florida. Her plan did not abandon her. Her cancer doctor's hospital abandoned her plan. The notice she received framed it as a routine network update. There is nothing routine about changing your oncologist in the middle of chemotherapy. Two versions of the same structural failure. The plan disappears or the care does. Both leave the senior exposed. Here is exactly what to do. Step 1. Determine whether your plan was terminated or your county was exited. Check the annual notice of change letter your plan was required to send by September 30th. If you did not receive one, go to the Medicare Plan Finder at medicare.gov and search your zip code for 2026 options. You can also call 1-800-MEDICARE, that is 1-800-633-4227, and ask directly whether your plan is active in your county. Do this first. Everything that follows depends on the answer. Step 2. If your plan was terminated or exited your service area, understand that you have federal guaranteed issue rights. This means you can purchase a Medigap policy, Plan A, B, C, D, F, G, K, or L, without medical underwriting. The insurer cannot ask about your health. They cannot deny you. They cannot charge you a higher premium because of pre-existing conditions. I covered in a previous video exactly why Medicare Advantage makes it nearly impossible to leave once you are enrolled. The medical underwriting barrier is the mechanism that traps people inside. A plan termination breaks that barrier completely. If your plan was terminated, the underwriting requirement vanishes. Plan G specifically is available under these rights, and it eliminates virtually all out-of-pocket medical costs after the annual Part B deductible. Step 3. Know your deadline. You have exactly 63 consecutive days from the date your Medicare Advantage coverage actually ended. Not from the date you received the letter, not from the date you called, from the date coverage terminated. For most 2026 plan exits, that was December 31st of 2025, meaning the 63-day window closed in early March. If your plan terminated later, some mid-year exits are still occurring, count 63 days from your specific termination date. If your window has already closed, contact your SHIP counselor anyway. State-level protections, including birthday rules, may apply to your situation even outside the federal deadline. And mid-year plan disruptions are still occurring. Baycare dropped UnitedHealthcare Medicare Advantage in June of 2026, and Moffitt Cancer Center is dropping Humana Medicare Advantage in July. Each new termination or major network change can open a fresh 63-day window for affected members. Keep the termination notice. It is your proof of eligibility. If you never received one, call your former plan and request a certificate of creditable coverage. Step 4. Call your state health insurance assistance program. SHIP is a federally funded counseling service that helps seniors navigate Medicare decisions. It is free. It is independent. SHIP counselors do not sell insurance and have no financial interest in your decision. They will help you compare every Medigap plan available in your state, explain the cost differences, and walk you through enrollment. SHIP counselors help thousands of seniors through the Nebraska, Delaware, and Maine cases where hospitals dropped Medicare Advantage networks and CMS granted emergency enrollment periods. They understand this process. Every state has a SHIP office. Find yours by calling 1-800-MEDICARE and asking to be connected. Step 5. Compare Plan G costs and enroll before your window closes. The national average Plan G premium for a 65-year-old is approximately $220 per month. After the annual Part B deductible of $283, your out-of-pocket medical costs are effectively zero. No network restrictions, no prior authorization, no referral requirements, no risk of your plan vanishing because an insurer decided your county was not profitable enough. Over the course of a year, that is roughly $2,640 in premiums plus the $283 deductible, under $3,000 total with near zero financial exposure beyond that. Compare that to Medicare Advantage, where the median maximum out-of-pocket cost is now $5,900 and rising. Networks are shrinking, and 21 hospital systems dropped MA contracts this year alone. The difference between completing these steps inside the 63-day window and missing it by a single day is the difference between guaranteed access at standard rates and the possibility of being denied coverage entirely. And that raises a question. Is there any path to guaranteed Medigap coverage if you are outside that window? Here is what almost no senior is told. 4 states in this country offer year-round guaranteed issue rights for Medigap: Connecticut, Maine, Massachusetts, and New York. If you live in one of those 4 states, you can purchase a Medigap policy at any time, regardless of your health, regardless of whether your plan was terminated and regardless of whether any deadline has passed. The 63-day window is not your only chance. It is always open. 8 additional states have what is called a birthday rule: California, Idaho, Illinois, Louisiana, Missouri, Nevada, Oklahoma, and Oregon, which gives you a window around your birthday each year to change coverage with some protections. The rules vary by state, and not all of them apply to a Medicare Advantage to Medigap transition, so verify with your SHIP counselor before relying on one. If you live in any of the remaining 38 states and your Medicare Advantage plan was just terminated, the 63-day guaranteed issue window may be the only chance you will ever have to buy supplemental coverage without medical underwriting. If you are healthy right now, the urgency feels abstract. If you develop a serious condition next year and you miss this window, there is no appeal and no second chance. 2.9 million seniors lost their Medicare Advantage coverage heading into 2026. The Johns Hopkins study published in JAMA confirmed a tenfold increase in forced disenrollments. UnitedHealthcare, Humana, and Aetna pulled back simultaneously because the financial model that funded their plans stopped producing the returns they needed. Hospitals are dropping contracts. Benefits in surviving plans are being cut. And the seniors who were told this was a better version of Medicare are finding out what happens when the private insurer decides your county is no longer worth serving. I covered previously why Medicare Advantage creates a system that is nearly impossible to leave once you are inside it. What is happening right now is the rare exception, a forced termination that triggers federal guaranteed issue rights, overriding the underwriting barrier that keeps most seniors locked in. That right is real. It is law. And for millions of people, it is a one-time opening that will not come again. If this changes something for you or someone you know, subscribing means you will see what comes next. There is more to cover on the structural changes inside Medicare right now. If you have a parent, grandparent, or neighbor on a Medicare Advantage plan, send them this video. 2.9 million people lost their coverage, and most of them do not know about the 63-day window that could protect them from unlimited out-of-pocket medical costs. That window is closing right now for many of them. I will see you in the next video.